Hi, my name is Salam and I'm here with Mark, Beck, Aryan, and Rashmi. Today we'll be discussing the case of Mrs. Joseph and breaking down the clinical manifestations, pathophysiology, diagnostic tools, and the pharmaceutical actions. I'll begin by discussing the clinical manifestations that Mrs. Joseph presents with that cause the escalation of a MET call. Starting with breathing, the respiratory rate of 38 is in the red zone and the patient is tachypneic. It is also noted that on auscultation, a diffuse crackle is heard. This confirms that there is a buildup of fluid present in the lungs, and Mrs. Joseph is currently suffering from a pulmonary edema. Due to the buildup of fluid in the lungs, the patient presents with a decreased oxygen saturation of 86% on room air, and this is increased using supplementary oxygen. Moving on to circulation, the heart rate is at 113 beats per minute resting, which is tachycardic. Mrs. Joseph's heart rate is compensating for the low blood pressure of 88/62 by the activation of the sympathetic nervous system. The sympathetic nervous system increases the heart rate in an attempt to bring up the blood pressure, but it is not the case in this patient due to her hypovolemia, and the blood pressure still remains low. Hypovolemia in this case is caused by fluid leaving into the extra-arterial and capillary space, such as organs like the heart and other tissue, causing the pitting edema and a panasystolic murmur. For disability and exposure, Mrs. Joseph is noted to have a reduction in her CGS of 1 point and also needing assistance to mobilize. This is expected for an individual who is both hypotensive and has high blood glucose levels, resulting in cell starvation, improper function of organs and cells due to being poorly perfused and leading to a lack of oxygen reaching the cells, and glucose not being able to enter the cells. It is noted that the temperature is at 37.8, which at this stage leads us to believe that Mrs. Joseph either has an infection or her brain function is altered due to her symptoms. The low-grade fever that the patient presents with is further exacerbating her condition due to the vasodilation that the fever causes. The pitting edema is, as discussed earlier, is caused by improper heart function, which is further confirmed by her right JVP pulsation. Mrs. Joseph is also a diabetic and is experiencing a hypoglycemic event, which is concerning as glucose is needed by all cells and tissue to function and survive. The discussed above are all of high importance, therefore triggering a MET call. I will now be passing you over to Mark, who will explain this further.
Okay.
Hi, I'm Beck, and I will be discussing question 3. Chronic cardiac failure, if left untreated, can progress to acute pulmonary edema, which is what Mrs. Joseph is diagnosed with. Due to Mrs. Joseph's complete heart block back in 2022, this would indicate that the myocardium has suffered ischemia and caused cell death within the location of the ischemia. Once the heart has suffered from cardiomyocyte death, the heart is unable to contract as effectively due to the myocardium wall becoming thicker and rigid. This also affects the heart's stroke volume, contractility, and the workload of the heart increases. When the heart's cardiac output reduces, the blood flow also reduces, which leads to the activation of the renin-angiotensin-aldosterone system, also known as the RAAS, which causes vasoconstriction and increases blood volume. This then sets off the sympathetic nervous system to constrict blood flow even more and release the antidiuretic hormone, which causes further water retention within the body. In 2022, Mrs. Joseph was diagnosed with a left ventricle ejection fraction of just 29%. A normal heart's ejection fraction should be above 50%. Mrs. Joseph's heart is unable to effectively contract and eject the correct percentage of blood out of the ventricle, which leads to the pooling of blood within the left ventricle. When the ventricles are unable to eject the correct amount of blood, it will dilate and try to compensate for the amount of blood needed to be ejected, but this just leads to extra blood pooling within the ventricle. The heart tries to eject the extra blood, but due to the weakened contractility of the myocardium, the heart is unable to eject the extra blood that it has accumulated within the ventricle, so the blood just pushes back through the mitral valve and into the left atrium. Once blood is pooling within the atrium, it can flow back into the lungs within the pulmonary capillary bed and will sit within the lungs and affect gas exchange and increase pulmonary pressure. Mrs. Joseph is experiencing sudden onset of chest pain and a productive cough due to her heart's cardiac pressure being reduced, and the workload of her heart has increased, causing her blood to increase in volume, which is then leaking into her lungs, causing pulmonary edema. I will now pass over to Aria to explain question 4.
Hi, I'm Aria and I'll be discussing question 4. The two significant diagnostic results that are found in Mrs. Joseph are her creatinine level and her chest x-ray results, which are both closely related to the pathophysiology of congestive cardiac failure leading to acute pulmonary edema. As per the pathophysiology of Mrs. Joseph's creatinine level, consider her chronic renal impairment. In congestive cardiac failure, it reduces cardiac output, which leads to renal perfusion. It decreases the response of the kidney by perfusion and activates the renin-angiotensin-aldosterone system. It will increase sodium and water retention to improve cardiac output. Moreover, congestive heart failure will not handle the increased volume, which lead to an overload of fluid and increase the symptoms of heart failure. In Mrs. Joseph's case, her GFR is 15 ml per minute, which indicates severe renal impairment. It will reduce the kidney's ability, will release the waste product, control the fluid overload, and make it apparent through pulmonary edema. The creatinine level reflects that it has decreased renal function, which has worsened her volume status, leading to subsequent heart failure. This cycle of heart failure may worsen her renal function and decrease her clinical aspects. The chest x-ray reflects fluid overload and cardiomyopathy. The chest x-ray reflects fluid overload and cardiomyopathy, which can be found in patients with chronic heart failure. While the heart could not handle the overload of blood, it is back into the pulmonary circulation, which leads to increased hydrostatic pressure. In the pulmonary capillaries, the pressure forces the alveoli and the gap between these tissues can cause pulmonary edema. Cardiomyopathy is a heart covering system where the ventricles improve to manage the increased blood volume. Looking at Mrs. Joseph's chest x-ray clearly shows signs of pulmonary clog and cardiomyopathy. Fluid overload diffuses the noises heard on the chest, auscultation, and the low oxygen saturation while having high flow oxygen. The cardiomyopathy related to her history mainly decreased her LVEF by 29%. It increases and shows how the heart reflects chronic overload and insufficient pumping, which contribute to the blood flow in the pulmonary circulation. The backflow of the blood can cause pulmonary edema, which can cause shortness of breath and both effective coughing and breathlessness at night. It reflects on the cold parts of the body, which may lead to heart failure due to diagnosis of heart failure. I will now pass over to Rashmi to explain question 5.
Thank you, Arya. I'm going to discuss about question 5. As in the case study, Mrs. Joseph have diagnosed with acute pulmonary edema and congestive cardiac failure. The two drugs that could be used to improve her clinical condition are intravenous furosemide and intravenous nitroglycerin. Furosemide work by blocking the tubular co-transport of sodium and chloride to the proximal, distal, and thick ascending loop of Henle, resulting in excessive water excretion along with the excretion of sodium, chloride, and magnesium as well as calcium. In the case of Mrs. Joseph, who's presented with severe respiratory distress and evidence of fluid overload, furosemide plays a critical role to reduce fluid overload in acute pulmonary edema. Furosemide promote diuresis that reduce the amount of fluid in the intravascular and interstitial spaces, which improve pulmonary congestion and respiratory function. This drug also reduces preload and afterload, which reduce the risk of future heart failure. Intravenous furosemide can be given 20 to 40 mg Repeat at interval at least 2 hours until the desired diuretic effect is obtained. It works primarily by blocking the reabsorption of electrolytes from the kidney and enhancing the excretion of water from the body. The adverse effects of furosemide are mostly related to the dose, such as electrolyte imbalance, dehydration, metabolic alkalosis, increased creatinine concentration, hypertension, etc. But in the situation of Mrs. Joseph, she might face electrolyte imbalance, which can cause a cardiac arrhythmia. As Mrs. Joseph has a history of cardiomyopathy and the insertion of a pacemaker, it is essential to monitor her electrolyte on regular basis. This includes blood tests for potassium, magnesium, and renal function. In addition, it is necessary to monitor for the sign of dehydration and hypotension because excessive diuresis can lead to complication. The second drug that can be used for Mrs. Joseph is nitroglycerin because it is a fast-acting vasodilator and manages chest pain due to acute coronary syndromes. It is also used to treat pulmonary edema and aortic dissection. Nitroglycerin increases blood flow to the myocardium and decreases cardiac preload and afterload. This reduces stress on the myocardial wall and improves anginal symptom. It is also reduces coronary artery spasm, decreasing systematic vascular resistance as well as systolic and diastolic blood pressure. Nitroglycerin helps reduce preload and afterload by reducing the heart's workload and improve its efficiency. In the case of Mrs. Joseph's condition, who is suffering from acute pulmonary edema due to congestive heart failure, reducing preload significantly reduces the amount of congestion in the lungs, improves oxygenation, and reduces the work of breathing. Also, by reducing afterload, nitroglycerin decreases myocardial oxygen demand, which can improve cardiac output in a heart that is already suffering from a low left ventricular ejection fraction of 29%. The main side effect of nitroglycerin is hypertension, so it can be major concern for Mrs. Joseph because her blood pressure is already very low at 88/62. While administering, it is necessary to monitor her blood pressure to control the risk. The dose must be carefully titrated so that desired effect is obtained without causing severe hypotension. So if hypertension occurs, then the infusion rate should be reduced or discontinued, and other supportive measures have to be implemented, such as providing IV fluids. Thank you.